Is it on? Imagine taking your son or daughter to the doctor, assuming they have the stomach bug. After getting results back from several tests, you find out they have cancer. This is the sad reality of how many people find out that their children have cancer. And this is one of the reasons I decided to go into pediatric hematology and oncology. Hi, my name is Olivia OW, and this year I'm studying pediatric hematology and oncology, which is the study of blood disorders and cancer in children. This is my second year in ISM, and I studied the same topic with the same mentor last year as well. So this is just a continuation of last year for me. I decided to take ISM because of the connections that it would offer me into the real world, especially since I wanted to go into the medical field. It'll give me a foot in the door for trying to get into a good medical school and being able to show that I've already had experience. And I also took it for the educational purpose of being allowed to shadow my mentor and actually get firsthand experience in education being inside the hospital. My quote for this year is, "When you can't change the direction of the wind, adjust your sails," by H. Jackson Brown Jr. I chose this quote because it relates not only to my journey through ISM, but also relates to the field that I'm studying. Children can't change the fact that they have cancer, but they can change their mindset and the way that they look at it. With a more positive mindset, they have a better chance of quicker recovery and just an overall better quality of life. And it applies to ISM because not everything is going to go exactly the way I planned. I'm not always going to be able to get the results that I want, especially with the final product that I've decided to choose. And so I can't just have my mindset on one thing. So if something doesn't work out the way I plan, I need to be able to be flexible. So that's kind of my motto this year. So since this is my second year and I had the same mentor, I am just going to recap last year in ISM. So I'm going to talk to you about my 3 main interviews and my 3 main research points. My first interview was with Dr. Patrick Levy, and he talked about the frustration of not being able to cure patients. And it was really relatable because being in the field of pediatric hematology and oncology, you're not always going to be able to help everyone the way that you plan on helping them. And so it's obvious that there's going to be some frustration, but that is also kind of a motivator to do more research and figure out other ways to possibly cure patients. Something that stuck out to me that he said was when he went into the patient's room, whether it was in clinic or an inpatient, he had the mindset that he was just going to forget everything else and just immerse himself in the family's life so that it would give the family a more comforting feeling that they could talk to him, he can relate to them, and they can feel comfortable and know that he's giving their patients, their children, the best treatment that he has to offer. He also talked about the 3 main types of treatment for cancer, which are radiation, chemotherapy, and surgery. And each cancer is treated differently, and they can either be treated with one of those or a combination of 2 or 3. He also talked about the importance of clinical trials because they help the doctors figure out new ways to help to treat the cancer that these kids have, because each cancer is so different and diverse that you can't just have one treatment and one option for each type of cancer. The next person I interviewed was Dr. Andrew Coe, and this was a really mind-opening interview because I had only thought about the clinic side of pediatric hematology and oncology and never really thought about that there is a lab component to this job. And so when I went there, I was kind of surprised about the environment, but it was really cool, and it made me second guess that I wanted to go into clinic. Like maybe lab would be good for me because I really like to expand my knowledge. And this ties into, he asked me to ask myself what motivates me, either the intellectual side or the emotional side. And if I chose intellectual, then he said lab. And if I chose emotional, then he said clinic. And I decided that not necessarily that emotion motivates me more, but when I thought about being a doctor, I thought about the patient-doctor interaction, and I really didn't want to lose that just because I had the intellectual desire. And throughout my mentorship last year and this year, I have learned that just because you're on the clinic side doesn't mean that you're not going to learn. You have to continue to grow your knowledge about the subject because it changes every day. Other people come up with new ways of treating your patients with cancer, and so you need to be on top of that so that you can provide your patients with the best treatment. Another thing he talked about was that kids are more resilient to the treatment because their organs have less wear. They haven't been smoking or drinking or just being alive. They haven't lived long enough for their organs to actually have wear and tear, and so that shows that they're more strong and they're better prepared for this treatment that they are exposed to. He also talked about how you needed to be focused and stubborn, and the focus part was more like you can't try to think about too many things at once. You really need to be focused on treating this one patient and this patient. Like when you're in one room, focus on them. When you're in another room, focus on them. But when you get back to the clinic in your command post, you can focus on more than one thing to get more stuff done. The stubborn part stems from the fact that if you have an idea that might not be commonly accepted, you need to try and push for it because it could possibly turn into something that is really beneficial and cure some types of cancer. And if you wait too long and are scared of being rejected, then someone else might discover it and then you won't get credit for it even though you had thought of it before. My last interview that I'm going to talk about from last year was my interview with Dr. Victor Aquino, and he specializes in bone marrow transplants, which is really interesting because you can have a wider variety of patients. Like, you don't always see patients who have cancer. You get to see patients who have blood disorders like SCIDs, and so you're not always doing the same thing and you're not always seeing the same side effects, so you just have more change and you're not constantly doing the same thing, and I liked that about what he did. He also talked about the high survival rate of children's cancer, which is 70% to 30%, and knowing that you're going into this field and knowing that it can be really depressing, hearing that survival rate really makes it seem worthwhile to go into it, knowing that you're not always going to have to be telling the parents that their kids are dying. You can say, I've treated them and I've cured them and they should have a long, fulfilling life, whereas only a couple of times you might have to say that they're not going to make it. So that just makes it a lot more worthwhile and easier to grasp. He previously studied immunology, and that helps him because the chemotherapy isn't a localized treatment and it affects the immune system of the patients. And so with his background in immunology, he can better assess his patients and treat them more effectively. I also last year chose Dr. Aquino to be my mentor, and we've had some awesome experiences being able to shadow him, and I've learned so much more from him than I ever could have reading about this field or just imagining what it would be like. Next, I'm going to talk to you about my three most important researches from last year. So the first was the effects of cancer and the treatment. So chemotherapy isn't a localized treatment and attacks all the cells, which causes a weakened immune system, which makes them more susceptible to other illnesses, which is why often they're hospitalized or you see them wearing the mask, because it's not that they're sick, but it's that we could get them sick, the people that don't have cancer, because they're not immunized anymore. And so if you're not immunized and you have measles, they have a higher chance of getting it, and measles might not kill you, but it could probably kill them since they don't have the T cells and the B cells to fight it. This article also talked about the physical and emotional effects of cancer and how it wasn't always true that the physical effects were harder, because the emotional stays with you longer. You remember this treatment long after you've had it, and it can have effects of scarring effects, making you not want to go back to the doctor because you've been poked and prodded. But they have, with medical advances, come up with like the port, which eliminates being poked every time that you have to be given chemotherapy or have your blood taken. So that eliminates that somewhat. This also talked about something that I never really thought of, which was the effects after relapse. So I assumed that if you relapsed, you had the same cancer. So if you had AML and you relapsed, you would have AML again. But this article actually talked about how if you had Hodgkin's lymphoma, many who relapsed had leukemia. So I thought that was interesting. Another thing I researched was chronic GVHD, which is probably one of the most important things I've researched because my mentor is always talking about it and I really needed to be educated in it. And so what GVHD is graft versus host disease, and that is basically where your host cells attack the graft cells. They see them as invaders, and once they've attacked all of them, they begin attacking themselves. And so the most common side effects of GVHD that you see are rashes, diarrhea, fever, vomiting, and these aren't usually fatal, but if you do not report them to your doctor and you let them persist for a long period of time, they can be fatal. And it's uncommon 1 year after your transplant. It usually just happens right after, before you have complete chimerism, which means you have full engraftment. And it mainly happens when you have a mismatched donor or an unrelated donor, because the chances of the HLA tissue typing being wrong are higher. The last thing that I researched last year was understanding a patient. And this was something that was really important to me because I know if I had cancer that I would be really unsure about the treatment I was getting. Maybe it wasn't the best that they could do because even though it is really studied, they don't know everything about it. And so from this article, I learned that people need to be educated on cancer, that people are naive to know the symptoms and how common they are. They're not necessarily these striking symptoms that you see. They're just like, you just might be nauseous or fatigued a lot, or you get bruised easily, and you might have leukemia, but you don't even know it. You just think you're tired and you have like the flu, the achy type of flu. And so it's really important to educate people on cancer. And then cancer is emotionally and physically draining, and it's something that you need to be able to talk with your patients, that they can't let it totally deteriorate them, because if they're so tired and emotionally tired, then they might not want to get out of bed, and it can delay their healing. Another thing it talked about was it takes a toll on their everyday life, and they think no one understands it, which is pretty understandable, because if you had a serious disease that not many people have, then it would be hard to think that anyone else could relate to you unless they've already had it. But as the physician and someone who treats cancer on the daily, you need to be able to relay to them that even though you may not have had cancer before, you understand what they're going through in a way, and that they can help them, that you can help them, and they need to be comfortable talking to you so that they can get the best treatment. So the current research I'm doing right now is centered mainly on bone marrow transplants, because that's what my mentor focuses on. Last year I was kind of just testing the waters and really figuring out what pediatric hematology and oncology was all about. But this year I've tried to center in on mainly the things that my mentor does, so I can have a better grasp when I'm on my mentor visits. So the first thing I researched was bone marrow transplants. And a bone marrow transplant is basically when you take blood from a donor and you filter out the marrow or the stem cells, and then you put it back into the recipient. And the whole point of the bone marrow transplant is hoping that the recipient will engraft the donor's cells and basically cure them, because they will no longer have their old cells. And a big part that plays into engraftment is the conditioning that they have before a bone marrow transplant. And conditioning is basically intensive chemotherapy and busulfan, which is just another drug that basically wipes out their immune system in most of the cancer or blood disorder that they have. And the goal is to get it down to below 10%, because if it's higher than that, chances are that then the new donor cells won't engraft and the cancer will just overtake the donor cells as well. So that's a really important factor when thinking about giving someone a bone marrow transplant. And there's two types. So there's an autologous bone marrow transplant, which is really uncommon because it's the use of your own marrow. And most of the time, you're too sick and most of your marrow has been affected that you can't use your own. But in some cases, you can. But the most common is an allogenic, which is where a healthy donor donates their marrow to replace the recipient's. And it's more risky because the HLA tissue typing might not be the same, and that's what causes the graft versus host disease, is when it's not matched properly. And so that's the risk you run having an allogenic transplant, but it's just the most common. And you have to be isolated for an extended period of time afterwards, since you have just had your immune system wiped out and your body's trying to re-engraft these new cells. You don't have a lot to function with, and you need to be in isolated care so you don't get sick. And so this is just an up-close image of how a bone marrow transplant actually works. So over here you can see that the stem cells are basically, blood is drawn and it's put into a petri dish, and they filter out what they need, whether it's stem cells or bone marrow, and they mix it with other things like antibodies and things that, so it's not just straight marrow going back into your blood. And then when it's ready, they take the marrow 2 weeks before you actually get your transplant to do all this to it. So it has to be frozen and kept at the proper temperature so that it can be reused. And then they infuse it, and then we wait and we hope that it works. So the next thing I researched was fatigue, and I tried to stay updated with this research on fatigue. Since I'm trying to start a clinical trial about fatigue, I want to make sure that mine's completely up to date before it's sent off and I have all my information right. And so the main reason that I chose to study about fatigue is that by physicians and professional researchers, it's poorly studied because it's not deathly. No one really dies of fatigue, and so it's not an urgent thing to fix in the patients. It's just something that becomes inhibiting to their quality of life and just their day-to-day basis. It's not like they have a tumor or they're having heart problems or they have a fatty liver. Those things need to be addressed quickly, whereas fatigue doesn't. Another problem with fatigue and trying to address it is that it's relative. My description of fatigue and the way I feel fatigue could be totally different than the way any of y'all feel fatigue. So it's really hard to decipher between whether they actually have fatigue, or maybe they just feel a little lazy, or they feel run down, or they might even have a mental disease like depression or something. It's something that scales need to be built so that you can decipher which you can use if it's fatigue. And it's caused by a variety of reasons, but when it's associated with cancer, it's usually caused not really by the cancer, but the treatment and the process that they have to go through. And so this is a diagram of 419 patients that were surveyed who received chemotherapy and radiation, and it was a survey to see how many times they felt fatigued. That was debilitating, not just tiredness that they could sleep off, but fatigue that actually inhibited them from doing their day-to-day basis, their day-to-day things. And as you can see, the biggest chunk felt it every day. And so clearly that strikes a problem. Even though only 20% said they felt it hardly ever, as a total, 78% of them have experienced fatigue. And so that clearly should signal a bell that something needs to be done, because they don't just describe it as regular fatigue and tiredness, they describe it as debilitating fatigue. Another thing I researched was Glanzmann's thrombocythemia. And the reason I researched this was because my mentor actually treated a patient who had Glanzmann thrombocythemia, and it's a super rare blood disease that is where you lack platelet aggregation, so you can't clot properly. And so you have a lot of excessive bleeding, or do you need to get that? Excessive bleeding or gingivitis, things like that. And it's really rare because it's a recessive disorder, which means that you would have to have 2 little g's to get it. And the main way to get that is if you marry in consanguinity, because the chances of both your parents having that recessive G and giving it to you are much higher, and that's why it's mainly found in the Middle East, France, and India, because it is something that is deemed okay to practice there. And right now, there's no definite curative treatment, but it is being experienced by treating, it is being cured in some places by treating by being treated with an allogenic transplant. And the reason that there's no definite cure, in my opinion, is that since it's so rare, they don't have enough people to ever enroll in a clinical trial or study for long periods of time to see what could be used to treat them. So the stuff on the side I've already talked about, but the main thing I wanted y'all to see out of this picture was the picture on the right side, which showed what they're lacking right here. So they either lack the GP2B or the GP3A, which is the clotting that allows them to clot, and they lack it. The next thing I researched was thalassemia major, and my mentor also treats patients with this, so that's another reason that I researched it. And the characterization of thalassemia is lacking oxygen-carrying proteins, so your red blood cells they receive the oxygen, but they can't hold on to it, so then it just gets dismissed before it actually gets to the tissues where they deposit it in a normal body. And so as of now, it's a lifelong disease with no cure. However, there are experiments going on and people have been cured by treating it with a bone marrow transplant. However, it's really risky because of their current state before they even have the bone marrow transplant. And so getting it done with an unrelated matched donor causes more problems than having it done with a sibling or a parent, because you're already related to them. And so chances are the typing won't be wrong and it can match up perfectly. And so this picture shows the way normal red blood cells work, where the oxygen is gone into the red blood cell and then carried and released to the tissues. And so basically this is just showing you that this is how our body functions, but they lack this end part. It never gets released into the tissues. The last thing I researched was late effects, and I try to keep up with new things about late effects as well, because it's something that as cancer has become more curable and more treatments have come around, late effects is now becoming a target, a focus, because more people survive cancer and have these late effects that no one has thought about or seen or tried to come up with a way to treat them. And so now it's becoming really important to know a lot about late effects and having special clinics that these patients can go to be treated for late effects. My mentor's hospital, Children's Health, has a program called ACE, After the Cancer Experience, and so they see that clinic once a year to make sure that they're not having any of these late effects, and if they are, then they can treat them. And this persists from the day that they're deemed cure to the day they die. And so late effects is basically a medical condition that occurs months to years after transplant, but can be linked to the cancer, the chemotherapy, the treatment that they got while they had cancer. And it can start during the treatment and just continue to persist, but usually it's a new late onset problem, and they range from mild to life-threatening. So you could just have a continuation of nausea, or it takes a longer time for your hair to grow back, but other people have heart defects, or they relapse and get a new kind of cancer, and those are the more life-threatening ones that they need to address quicker. The next thing I'm going to talk about is my original work. And for my original work, what I did was I researched non-malignant diseases and malignant diseases, so that means cancer and non-cancer diseases that can be treated with a bone marrow transplant. And the purpose of this was to learn more about non-malignant diseases, since my mentor treats a lot of them because they're treated with bone marrow transplants, and that's what he specializes in. I don't necessarily know as much about these disorders, and this original work has really helped me learn about them and their side effects and ways they can be treated. And another thing was just to learn more about bone marrow transplants. And the way this was really original is that doctors don't ever sit around and say, oh, my patient has diamond blackfan anemia and your patient has acute myeloid leukemia. Which one are we going to give the transplant to? They don't do that. There's so many donors out there right now, they want to cure both of them. They're going to try and find a way to treat both of them. They're not going to think about it that way. So it's really not discussed much in the medical field because that's not their mindset. Their mindset is to treat everyone so that they can live their life to the fullest. And so my process for my original work was lengthy. I had to read many textbook chapters on different non-malignant and malignant diseases. And at first I was like, this is going to be great. But as I started reading the first sentence, I realized I had no idea what these textbook chapters were saying. So on top of reading the textbook chapters, I had to go to outside resources like medical dictionaries or research other articles to find the words that I didn't understand in context so I could figure out what they meant, which really extended the length of the researching aspect of my project. And at first I was researching like every 2 or 3 words because I'm not a medical student and I haven't been taught how to read the language that they use in their textbooks and how to interpret it. And so that is something that I learned from this project, was definitely how I can better understand medical terminology, the textbooks, the language they use, which is going to be a really big help for me in the future as I go into medical school and I take pre-medical classes. I'll already have a grasp on really what they're trying to get across in these textbooks and how things are worded. Then after I did my research, I made my own analysis and decided if I thought it was better for a non-malignant disease to be treated with a bone marrow transplant or malignant disease. And I sent it to my mentor for feedback. And to my surprise, he agreed with me. And so that made me feel really good. It made me feel like I actually kind of knew what I was talking about when I was researching and writing this article. So here are the pictures of my project. It's just really an essay or a assessment. And so that's what I did. And so what I decided was that non-malignancies are more successful. And I decided this because their immune system is already suppressed before they come in. So since their immune system is already suppressed, they don't have to go through as harsh of conditioning, which is usually where a lot of the problems stem from, is that harsh chemotherapy or radiation that the patients have to go through before the bone marrow transplant to wipe out their cells so that the other ones can engraft. Well, they don't have to go through as harsh, and so they won't get sick from that, and they won't have late effects from that, they won't have side effects, and so that really is probably the #1 reason that it's better. And also, the success rate is much higher in a non-malignancy because once it's cured, it's cured. It doesn't come back. Like cancer relapses, but if you have Fanconi's anemia, once it's cured, and you're not going to get it back. And so with that in mind, seeing that if you had one bone marrow transplant that you could use that matched 2 patients, one with Fanconi's anemia and one with AML, and you know the success rate is going to be higher in Fanconi's anemia, it seems pretty obvious that you would treat them. And the reason that malignancies are worse is because the #1 failure of the bone marrow transplant is relapse. And it's really something that can't be prevented by any medication or treatment. Sometimes the treatment triggers new cancers, especially in women if they have lung cancer and they have to get radiation around their breast, then that can trigger breast cancer. And so malignancy patients have many more late effects or side effects from the treatment and the conditioning, which makes them less of an ideal patient to treat with a bone marrow transplant. And then another reason that non-malignancies are better is that they have a less likely chance to get GVHD or graft rejection, because since they have to go through less conditioning because their immune system is already suppressed, they have a less chance because they didn't have to go through that conditioning to wipe it all out. They didn't have it to start with, so the new cells just go in and they make a home for themselves and start engrafting. And